Welcome all. Today I am going to talk about NTEP. So first about the introduction, a little bit about the history. So National TB Control Program was planned from 1959 onwards, and it was started in 1962. And actually the infrastructure and all was very good, but there was some problems related to the program, and it was not achieving its aims and targets. So in 1992, uh, a reanalysis was done, and to overcome the lacunae in the NTP or the NTCP, uh, the government of India has introduced the RNTCP. There was collaboration with the one Swedish association and with WHO, and RNTCP was brought about. And along with RNTCP, an internationally accepted strategy called the DOT strategy, that is directly observed treatment short course strategy, was started, and it was started in 1993, and at that time it was piloted in 5 states, and in 1997 it was released as a nationwide program, and it was decided to increase in a phase manner. The program was decided to be increased in a phase manner, and gradually in 2006 it was covered. It covered the whole nation, and the RNTCP was built on the infrastructure framework that was put forward by the control program, right? And RNTCP was is said to be a very successful program, and it has achieved many milestones and targets in the due course. And now we have come to the scenario of ending TB, right? WHO for 2035 has brought about the end TB strategy. So in regards to that, and also in the course of ending TB in 2035, there's also SDG target to end the TB epidemic by 2030, SDG 3.3. So in the view to end TB target, the program has been renamed from RNDCP to now NTEP, National TB Elimination Program. It was a control program. Now it is converted to an elimination program. The government of India is committed to end TB by 2025. Actually, a national strategic plan is there that we will discuss later. From 17 to 25 to end TB by 2025, and that is 5 years ahead of the SDG goal to end TB epidemic by 2030. Now let us just see about the magnitude of TB in India. So this is a table that is given under the NTEP module. So there is globally 10 million TB cases, then out of which the 2.69 million is in India, that is the 27% of the global TB burden. Similarly, you can see the data here, 31% of mortality due to TB and 24% of the MDR TB. So India has a very considerable burden of TB considering the global scenario. So that is what it is written here. And about the HIV TB co-infection, so that is also a huge problem. So three first of all, HIV infection increases the risk of TB, that you might be knowing. 3% of incident TB cases in India were HIV positive. So HIV increases the risk of TB. So that's it. 55 to 60% of AIDS patients had TB sometime in their life, right? Sometime in their life, and in TB patient, the HIV viral load can increase 6 to 7 fold. That is, an HIV infected person newly infected with TB has a 16 to 27 times higher chance of developing the disease that among uh, like if a person is having HIV and he is having a latent TB, So there's latent TB and TB disease. Like we are all studying in medical colleges, and we might have been like exposed to the TB bacilli, and we will be having latent foci of TB. But that doesn't get activated, and all the people will not get TB, right? But when the person is having HIV, there is a 16 to 27 times higher chance of developing the TB disease. And why there is 6 to 7 times higher viral load is that in a TB patient infected with HIV, inflammatory response to TB bacilli is there, and that increases the HIV replication. So these are some of the values that shows why the HIV TB co-infection is there, and why in the program such a coordinated activity should be there. Even after successful treatment, TB recurrence can occur. Now, pediatric TB is also a huge burden. About 10 lakh children become ill with TB disease every year. And this is also important. Early diagnosis and treatment is important because 15 to 16 individuals per year is infected by an undiagnosed and untreated TB patient. So this is about the magnitude of TB in India. This is why TB program is given importance. And we will talk about this DOT strategy, that is directly observe treatment short course. Uh, DOTS is a systematic strategy to control TB disease, and it was brought along with RNDCP, and it has 5 components. There is a political and administrative commitment. That is actually a government's commitment to give continued financial assistance, human resource, and administrative support at every level, and an equitable distribution should be there. Good quality diagnosis, sputum microscopy, and other microbiological tool. And now there is CBNet that has been turned into a universal CBNet. Now, uninterrupted supply of quality drugs should be given. Fixed dose combination of anti-TB drugs are given as per weight bands under the RNDCP and NTEP program. Fixed dose combinations are given according to weight bands. Then directly observe treatment, that is one of the key elements. An observer watches and supports the patient taking their drugs, right? Observer can be a health worker, community volunteer, or a family member in special cases, right? So a person will observe the patient taking their drugs, that's it. And it ensures TB treatment adherence, okay? So that you are seeing the patient taking the drugs, that is the key. Now, next one under this DOT strategy, systematic monitoring and accountability. So, under R&D-CP, there are many key indicators like TB notification rate, treatment success rate, and these are monitored regularly at every level of the health system. So, a good monitoring system is established. So, that's about the DOT strategy. Now, let's look into the NTEP organogram. NTP is under the NHM. NHM is the flagship program of Government of India, and different levels the organization structure is there, and uh, at the national level there is central TB division. Uh, there is a national program manager and a deputy director general for TB. So program manager and deputy director general is there at central TB division, and the central TB division is supported by the National TB Institutes and the National Task Force for Collaboration of Medical Colleges. And under the laboratory framework, there are 6 national reference laboratories that you can read about. So that is at the national level, and at the state level office is responsible for the management of programs at the state, and the state TB officer is there, and he is answerable to the state government, and he will follow the regulations of the central TB division also. uh, under at the state level there is STDC, that is State TB Training and Demonstration Center, and under the State TB Training and Demonstration Center there are three units. That is a training unit is there, there's a supervision and monitoring unit, and third is actually under the laboratory there is IRL, Intermediate Reference Laboratory. Most IRL have culture and drug sensitivity testing, both genotypic and phenotypic methods. So that is at state level, and there is one thing called the state drug store per 5 crore population. Now at the district level, there is district TB cell, and there is the district TB officer. So the district, at the district level, it is the key level for management of primary health services in the district. Primary health services management and nodal point for the TB control in the district. So the establishment of sub-district level, that is one of the major organizational change under NTP. The TB unit was there under RNDCP also, but the sub-district level has been brought about under NTP. So the laboratory framework at the TB unit level is the designated microscopy center. The designated microscopy center can be established at different settings that we will see, and different populations are there. Just let's just go through that. So the TB unit is under the control of the MOTC, that is the MO, medical officer TB control, for TB control, right? So TB unit is set up in urban or rural area per 2 lakh population, right? That is the average 2 lakh population, and here 1 lakh population. For hilly and tribal, it is set up 1 TB unit per 1 lakh and 1 TB unit for 2 lakhs. So this is the range, this is the average, 1.5 to 2.5 in urban and rural, and 0.75 to 1.25 lakh population in hilly and tribal area. So there are two officers there, that is the state TB laboratory supervisor and senior treatment supervisor. So there are different criteria to increase these officers, and population criteria are all there. You can read that. Okay. Designated microscopy center, you can see rural or urban 1 per 1 lakh and tribal 1 per 50k population. In tribal and hilly, there will be in the peripheral unit, maybe the setup and the microscopy and all the facilities will not be available, and such areas will be named as collecting units, that they will just collect the sputum, they can't test it, and they will send to the nearby center. At the peripheral level, PHCs, CHCs, ART centers, medical colleges, private NGOs, TB hospitals, and what is the peripheral health institution? That is a institution that is manned by at least a MO is named. So all these come under that, and there is a TB health visitor per 1 lakh health urban population. So these are all minor facts, right? TB health visitors per 1 lakh urban population, and some PHI also function as a designated microscopic center. But as I said here, some PHI function as DMCs, but some PHI do not have the infrastructure capability and the lab setup. They will function as collecting units. So let us quickly revise the lab network once more, and few other points are also there to be included. The lab network is a 3-tier system. So there is a peripheral. So going from above downwards, it will be like this. But all the national program now are set to be below upwards, right? Bottom to top approach. I mean, I was just adding it here. So uh, peripheral laboratory, it is present in public and private sectors, like ranging from PHCs to medical college hospitals, NGOs, private sectors, etc. And some peripheral laboratories are assigned as DMC. I said earlier they will have good infrastructure facility. What all will be there are all mentioned in the NTEP document. If adequate facility is not available, they are collecting centers. Okay, they will just collect this people. So that is at the peripheral level, designated microscopy center. At state level laboratories are there. That is actually intermediate reference laboratories. They are mainly situated uh, in the state TB, state training and state TB training and demonstration center (STDC), or maybe at medical college hospitals, public health laboratories. And the functions is monitoring and quality assurance of TB lab services across the state. That is one function. And there are about 27 intermediate reference laboratories, and most of them have culture and drug sensitivity testing. Drug sensitivity testing can be phenotypic or genotypic methods. Phenotypics like liquid cultures and all, and PCR like genotypic methods are also there. You can see here there are intermediate reference laboratories, so 29 are there, sorry. And CBNAT sites are the, so now under the program it is universal CBNAT. So there is plan for increasing the CBNAT sites where you can diagnose the rifampicin resistance among TB patients, and also the presumptive TB cases among the key population. The diagnosis of presumptive TB cases among the key population is also done. Present in district TB cells, sometimes TB units and medical colleges. Now there is DRTB centers. So drug resistant TB centers may be of two types, that is DDR TB centers and NDR TB centers. NDR or nodal drug resistant TB center is at the state level, and the DDR district is at the district level. So they have a different function and different setups. Nodal DRTB centers are for seriously ill patients, extensive resistance TB, and also the administration of bedaquiline and delamide is done at this level. But MDR TB treatment, H mono or poly regimen treatment, these all can be administered at DDR TB centers. So drug resistant TB treatment is given at these centers, from these centers, right? And XDR is given from nodal centers. So they have different bedding capacity and all that will be dealt later. Next is central level. There are 6 national reference laboratory that is responsible for the quality assurance of the lab network, drug resistance surveillance, training and research. So under this program, that sub-district level is the new addition, right? The sub-district level. So TB unit is the nodal point at this level, and TB units are based mainly in NHM health blocks with overall aim to align with the NHM BPMU, that is the block program management unit, for optimum resource utilization and appropriate monitoring. So they are mainly based at NHM health blocks, TB units. TU is TB units, and TB care in private sector. So 70% of people are seeking health care at private clinics. So that is a huge chunk of the population, and the population that is seeking care at private is not well documented, and the data is not coming to the center. So under the NTEP, a standard for TB care in India has been established. So certain standards have been established. That is, standards are like what should be given or what should be done at that level for TB care. That is what it is said. What should be done. So, like certain problems were seen in private sector regarding the diagnosis and all. So, to overcome that and to get the complete data from there and all, so certain standards of TB care, like 26 standards have been developed after consultations from different areas. And these standards are like there are 6 standards for diagnosis, there are 5 standards for treatment, and so on at different levels. So certain standards what should be done has been mentioned. So for example, mandatory TB notification. So Nixchai, that is a mobile app, and for the registration and all, a web based system. Then there's a ban on zero diagnostics like the quantiferon gold. Certain zero diagnostic tests have been banned in India. So this is about the first part of NTEP.